Hello, my name is Luis Filgueira. I'm an occupational therapy student, and today I'm going to discuss my presentation for my Fieldwork 2 on Harlem Hospital, and it's about functional cognition on patients with TBI. And I'm going to do a little introduction first. I'm going to cover Harlem Hospital, the mission, the vision, and the values, what is OT, ADLs, IADLs, the relationship with functional cognition, what is a TBI, the prevalence, comorbidities, the strategies for functional cognition, assessments we use at the hospital, limitations of others we don't use, the common guidelines for TBI, and then the tip of the iceberg. One thing is what we see in a person, and the other thing is what is going through that person. When I found out at Harlem Hospital about the mission and vision, I was reading, I saw the Department of Rehab, they have OTs, OTAs, PTs, PTAs, speech language pathologists. So I was reading about the mission and vision, and I was like excited because they want to prevent impairments physically, but they also want to optimize participation in life. So I was like, I'm very interested in functional cognition, so to me it was an opportunity because I want to work in complex tasks, and this is a very good chance to see patients with a TBI, and then I can provide the best quality in order to keep them safe. What is occupational therapy? Some people they think that OT and PT are the same. I would say that OT is also functional therapy. So we are a health profession that promotes well-being through activities, through self-care like bathing, toileting, daily life things we do every single day, like going to the bathroom, feeding, eating. And then we have IADLs that are more complex, supporting the basic activities like taking care of your dog, of your child, and driving, and cleaning the house, making food. So ADLs and IADLs are very important in acute care. In acute care is you have to be medical stable, and then you start like rolling in bed, sitting, standing, start working, going to do toileting, but also you have to think about IADLs because this person has to get discharged, has to go home, has to be safe. Do they have family? They live alone? They have equipment? Did they use it before? How was the prior functional level? They have insurance? What equipment they will need? So when we see a person with a TBI, that is why I want cognition, we want to make sure that this person is going to be safe. What is a traumatic brain injury? It's a sudden injury that causes damage to the brain. It can be by a hit, a bump, hitting the head. And the Glasgow Coma Scale is the most common scoring system to describe the level of consciousness in a person following a TBI. Why is important assessing functional cognition? When we see patients, sometimes they are physically independent and they talk and it looks like everything is okay, but we need to determine if a patient is safely and effectively ready to participate based on the level of impairment and in dependence or independence to participate in the ADLs or IADLs, and we have to make sure that they are safe. This is a benefit for patients and their families, their caregivers. It's going to reduce their burden. We are going to give them education, and also it's going to contribute to reduce hospital readmissions because another injury in the brain. During my fieldwork, I see many patients holding a TBI. So based on data, 64 to 74 million persons sustain a TBI each year, and in America, in the United States, 1.5 million sustain a TBI every year. And males are nearly 2 times more hospitalized and 3 times more dying than TBI in females. Then also is a factor if they are young because of motor vehicle accidents, falls in babies and adults older than 75. But we can see that TBI is very high in the United States and in Canada. However, in low and middle income countries, they have nearly 3 times more TBI. When someone is having a TBI, there are many comorbidities or consequences. Some patients can have early dementia, it's a risk factor, psychiatric disorders, PTSD, or even headaches, fatigue, or seizures and epilepsy. Seizures are very common. In patients with TBI, even in mild TBI, there are common cognitive problems. For example, attention and concentration. In these cases, the OT can consider working with the patient in a quiet room, focusing on one task at a time and gradually make the task harder, or consider breaks when the patient is tired. For processing skills, the OT can decrease distractions, allow more time to think before moving on or reading, rereading if needed, taking notes and summarize. For memory, the OT can help with memory aids such as memory notebooks, calendars, daily schedules. We are a very big team, so we can refer all the time to other professionals. And in the case of communication, OT can refer to a speech language pathologist, and in addition can speak slower to the patient with simple words, or asking a question and determine if the patient is understanding. In planning skills, the OT can make a list with what is first and break down activities into smaller steps. For reasoning and problem solving, the OT can work through step-by-step problem solving, like brainstorm solutions, the pros, the cons, pick a solution and try and check if it works or not, and then try another one. And for controlling the impulses, the OT must give realistic feedback, provide clear expectations for desirable behaviors before events, and establish verbal and non-verbal cues to signal the person to stop. At Harlem Hospital, we use many assignments, but I would like to discuss a little the most common assessments for patients holding a TBI. One is Rancho Los Amigos, the other is Zaidi Talks, and the modified version of Kettle Test. So OTs utilize activities and occupations as means and also as ends to engage patients with TBI to assess their functional cognition, such as initiation, sequencing, termination, time management, and the ability to perform real-world tasks, and to evaluate patients' awareness to attention to environmental stimuli throughout the activity. These assessments inform about the post-discharge level of functioning, including self-care and personal value roles, routines, and IADLs. In Rancho Los Amigos, usually I see patients from level 1 to level 6 before they get discharged. So in level 1 they look like asleep, intubated, and they don't have any response, even to pain. And level 2 I see patients that they might be a little inconsistent and they react slightly, but they are not asleep. For level 3, the response is inconsistent with some delays, but if you say hold my hand, squeeze my finger, you can see sometimes some interaction. For number 4, you can see the behavior that is very inappropriate. And in number 5 and 6, they are still confused in number 5, and they follow commands, but the answers are not appropriate. In number 6, they are appropriate, but they are having problems with new tasks. As described before, decreased awareness is the inability to recognize deficits or problems caused by a neurological injury. Since the patient does not acknowledge impairments, they might not be motivated to compensate for them. There are here two concepts. One is psychological denial, the other is impaired self-awareness. In psychological denial, the patient shows partial or implicit knowledge about themselves. They might resist or become angry when giving feedback, or they are trying so hard, struggling to work with new information about themselves. In cases of impaired self-awareness, patients lack information about themselves. They might experience confusion when giving feedback or functional limitations. They can be indifferent when asked to work on new information about themselves. When addressing self-awareness, we have to check the 3 levels to make sure that patients can be safe to go home or not. Intellectual awareness, the patient might be aware that something has occurred, but they don't know how to identify it. In emergent awareness, they might recognize the impairment as it occurs. And in anticipatory awareness, they can anticipate when the impairment will affect their performance in the near future to implement the strategies. When asking these 3 questions, how do you feel now compared before the brain injury, or if you have something different affecting you in your daily life, or what do you hope in the next 6 months? The first question is addressing intellectual awareness, the second emergent awareness, and the last one anticipatory awareness. At Harlem Hospital, in my fieldwork, I'm using a modified test of grocery shopping skills, and to include a working memory asking the patient to immediately recall 5 items: apple, banana, bread, eggs, and milk. And then I assess categorization and topographic orientation, asking in which section of a grocery store the patient will find each item. We also assess arithmetic reasoning, asking the patient what remains of their paycheck of $200 if it is taxed 10%. And by the end of the assessment, we ask patients to recall any of the 5 items if they can remember. I'm also assessing and administering with a modified version of Kettle Test, asking a verbally sequence through preparation of a cup of tea or coffee, depends on the client or the patient, from beginning to end. We are assessing safety awareness during the task, initiation, sequencing, and termination. In addition, we ask patients to follow a 5-step sequence. Take this water pitcher, bring it to the bathroom, empty it out in the sink, refill it, and bring it back. And lastly, we assess patients to correctly verbally sequence through navigation from 135th to 125th Street by walking to assess safety awareness, sequencing, attention, concentration, and topographic orientation skills. And speaking about orientation, we are assessing patients' orientation to person, time, place, and situation. However, we don't use the mini-mental state examination or the MoCA because they have a limitation in ability to detect dementia. They are not very sensitive, and it depends also on the patient's age, education, culturally, socioeconomic status, so it can result biased. I was looking for the common TBI guidelines and protocols to see how proceed when something is specific, but there is no single uniform TBI literature to support a comprehensive best practice. So physicians, nurses, OTs, and other professionals, they find the most current information in specific journals, and this is very challenging to stay with the literature. There are many freely available guidelines to focus on different aspects of TBI management, but there are many variations in children, adults, military or athletes, and settings with different severities or injury, like mild through severe, and also stages of recovery in TBI. There are no single guideline, however, encompasses all severities and populations across care settings, and variability in guideline quality exists. Third, we're following guidelines and recommendations for patients with TBIs. Maybe it's because of the time and resources are depending upon hospitals, there are variations in patients, and requires multidisciplinary efforts for coordination. When seeing a patient with a TBI, there is something visible and something that is invisible, and we have to be aware of that. The visible areas are physical symptoms such as loss or change in consciousness, seizures, nausea, vomiting, involuntary movement, paralysis. Another visible areas, motor difficulties such as loss of motor skills, imbalance, gait, dizziness, vertigo, and poor coordination, and communication challenges such as slurred speech, difficulty following conversations, emotional outbursts, and personality changes. However, addressing the whole person, we should be aware of cognitive deficits, and they are sometimes not visible, such as confusion, memory impairment, difficulty concentrating and or processing, remembering, and in addition, there are also emotional effects such as PTSD, feeling of isolation and anxiety, psychological effects such as loss of self, identity, frustration from lack of understanding, frustration from non-linear recovery, easily confused, difficulty to find vocabulary to explain symptoms, and there are also other effects such as sleep disturbances, chronic pain, migraines, headaches, emotional lability such as sudden outbursts or laughter or crying, depression, getting stuck in a single thought, noise and light sensitivity, visual problems, or hearing problems such as tinnitus. Working in acute care gives me the opportunity to work with patients with TBIs, and also is great to see that occupational therapy services address functional cognition and has been shown to lower hospital readmission rates.